Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Judy King, Consultant Medical Oncologist at the Royal Free Hospital in London, UK. Welcome to this program entitled Advancing Treatment for HER2-Positive Advanced Breast Cancer, Expert Analysis of the Latest Developments. Joining me today is Peter Fasching, Associate of Gynecology and Obstetrics at the University Hospital Erlangen in Germany. So, as everybody knows, there's been a huge expansion in HER2-targeted therapies in the last couple of decades, starting with trastuzumab, pertuzumab, moving through to the TKIs, and then more recently, the antibody-drug conjugates with initially TDM1 and more recently TDXD, which has made its way very much into the mainstream. And we're going to talk about the two studies today that have read out in the last 6 months, which is Destiny Breast 09, with the question of moving the antibody-drug conjugates to the first line, but then also the Patina trial looking at maintenance with the addition of palbociclib. So just to kick things off, a quick recap of DB09, which was presented at ASCO 2025. So as you'll recall, this was patients with metastatic HER2-positive breast cancer in the first line. So they could have had prior treatment in the early breast cancer setting or be de novo metastatic disease, but no prior treatment for HER2-positive metastatic breast cancer. And asymptomatic brain metastases were included. Now, importantly, there were 3 arms in this study, but only 2 have read out at the first interim analysis. So the 3 arms are TDXD on its own, TDXD with pertuzumab, or the standard of care, the Cleopatra regimen of a taxane with trastuzumab and pertuzumab. And the primary endpoint is PFS, with the key secondary endpoint of overall survival. Now, the interim analysis was presented. As I've said, the TDXD alone arm, the results have not yet been presented, but comparing the standard Cleopatra regime of THP versus TDXD plus pertuzumab demonstrated an improvement in PFS in favor of TDXD and pertuzumab. And the median PFS was 40.7 months versus the Cleopatra regime of 26.9. So clearly a very statistically significant difference there with a hazard ratio of 0.56, and also clearly clinically meaningful as well. In terms of side effects, I think it's fair to say that there were no additional side effects seen, with no new safety signals, although it is noticeable that there were 2 ILD-related deaths on study. And I think one of the things that we need to think about is that while the majority of the toxicities with the taxane, pertuzumab, trastuzumab combination would have been during the chemotherapy, there was also the maintenance phase or trastuzumab, pertuzumab phase, where the toxicities will be much lower, whereas with TDXD, this is given until progression, although patients were allowed to downscale to trastuzumab and pertuzumab maintenance. But one of the things that we do need to think about is how that will play out in terms of our patients' quality of life. So this is a really interesting study that I think we'll need to come back to. And I think those very positive PFS results, although an interim analysis, are going to be the topic of much discussion. And I'm going to hand over to Peter to talk us through Patina, which presented 6 months ago.
Well, first, Judy, it's always a pleasure to discuss new data with you. And thank you for letting me show the data of Patina, because I think it's a special study as it follows a concept, that was preclinically known already since 2009, where the data that was produced in UCLA lab showed that it's not only working in hormone receptor positive HER2 negatives, but also in hormone receptor positives HER2 positives. And now the Patina trial carries that into the clinics. Also a first-line study in HER2 positive and hormone receptor positive. And of course, up to now, after the initial treatment with the pertuzumab and the chemotherapy, we would keep these patients on the trastuzumab in combination with an endocrine treatment. And now the question was addressed whether the addition of a CDK4/6 inhibitor, in that case the palbociclib, can improve the progression-free survival. So the answer is very simply yes. The median progression-free survival time was extended from about 29 months to about 44 months. That's a 15 months benefit adding palbociclib in the maintenance phase after the ending of the chemotherapy. Hazard ratio was 0.74 and the p-value 0.0074. And of course, it's an escalation of the treatment. And it always comes with side effects that we might not have had if we wouldn't have escalated the treatment. And mainly with the palbociclib, the side effects were seen that we're already aware of. It's hematological side effects with neutropenia, but also fatigue was more frequently seen in patients treated with palbociclib and diarrhea and stomatitis. And that was quite rare in the treatment, of course, with only the trastuzumab and the endocrine treatment, which we know is always very well tolerated. So I think it's a great success to have two big trials in the consequence of two subsequent conferences improving progression-free survival. But of course, now there's a good discussion about, which patients should really get it. Should everybody get it? Or should other patients maybe not be treated with these more toxic treatments? But I guess we're getting into this discussion right now.
Yeah, so I think absolutely. And actually at ASCO and since you've been home, the discussion still rages. I mean, what's your feeling? I think there's been a lot of discussion about let's assume, yes, it's an interim analysis for DB09. We're not there yet. And we would need to see, especially that third arm readout with the TDXD alone. But if we assume that this is going to be a positive study, would it be TDXD for everyone? Or do you think that, are we going to see a difference with some people going down a patina line and saving TDXD for the second line? What is your feeling?
Well, I think with an extension of median progression-free survival of about 13 months, that's something that weighs pretty heavily on not giving that treatment, meaning we would have to find good reasons why we don't want to give that treatment. What would be those reasons? We have more side effects with regards to nausea. We have more side effects a little bit with regard to the hematological side effects. We have more side effects with regard to two therapy-induced deaths. These are things that have to be weighed in when making these decisions. So I think everybody would feel more comfortable having mature overall survival data. But up to then, I mean, we've been implementing the trials already with a median progression-free survival time as an improvement. And I think there's a good reason in patients, maybe with a high burden of disease, to adapt this treatment. But of course, I think everybody would feel more comfortable if the overall survival data would be already there.
Yeah, I mean, the tricky bit with the overall survival data, because the question is, we know that if people do get the Cleopatra regime first line, they can have TDXD second line, and that's had very, very good outcomes. But the problem with the study is that I don't think that we'll get the proper crossover, so I'm not sure we're going to get as the clean data that we would like. I mean, one of the things that my colleagues have been talking about is whether someone has had prior treatment in the early breast cancer setting, somebody who's had EC Taxol and adjuvant TDM1 and then a relatively short disease-free interval. I think that there are those patients where maybe you'd be reaching for the TDXD earlier, but is there something about, the ER positive metastatic breast cancers, if they're maybe a lower disease burden, would you be thinking maybe there are patients where you'd want to give the Cleopatra regime and then palbociclib maintenance?
Yeah.
Or is it?
I think what you just said is very important. Very different from other tumor types. We know that in HER2 positives, a large proportion of the patients present themselves in the clinics with a de novo metastatic disease. From the viewpoint of the metastatic breast cancer patients that come into the clinics, in the first-line metastatic patients, half of them are de novo metastatic, which also means that the other half already got a previous adjuvant treatment, either with TDM1, as you just mentioned, and or pertuzumab, either in the neoadjuvant or in the adjuvant setting. And of course, for these patients, it seems like a much more reasonable choice to choose now the TDXD as the subsequent therapy in the first-line setting, because the other therapy options were already tried and obviously were not enough to keep these patients from metastasizing. I think it might be a very different story in patients that present with de novo metastatic disease and haven't had gotten any previous therapy yet. There, what you just said might be applicable when they've been treated in the first line with a trastuzumab, pertuzumab. We have very good data that then in the second line setting, this treatment is much better than the TDM1, as we know from the Destiny Breast 03 trial.
And conversely, if we do give the Cleopatra regime first, then we know that the next line should be TDXD from DB03. But if we do give TDXD first line as per DB09, what would you give on progression?
Well, as usual, I mean, we have to learn about the efficacy of these treatments later on. And we had a very similar situation when the TDM1 and the pertuzumab were concomitantly developed. And we just learned later that the TDM1 has a very bad progression-free survival time after the pertuzumab, much less than in the Emilia trial, when the TDM1 was given without previous pertuzumab therapy. I don't have a good answer to your question, but of course, one of the main principles is to never let a HER2-positive patients without any anti-HER2 treatment. And with the tucatinib, I think there's treatment options that are available for patients in the HER2-positive setting, but also turning back to a trastuzumab-based therapy is something that has to be considered. The lapatinib is out there, even though we know it might not be the most efficacious anti-HER2 treatment, but the most important thing is don't let a patient without an anti-HER2 treatment. But we don't know what is coming after possibly adjuvant pertuzumab and TDM1, then first-line TDXD. It's very difficult to make assumptions about the efficacy of subsequent therapies. We have to learn that from the real-world data that hopefully will be generated rather quickly.
Absolutely. I think there's a lot more questions than answers with some of this. And I think that the other thing that we don't know, of course, is what the reimbursement will be in terms of the global access. So certainly across Europe, I would expect that there will not be uniform access, and it will not be the same as necessarily in the States. So it may well be that people are making different choices based on not only clinical characteristics and, level of disease burden, disease-free interval, and so on, but they may well be making different financial decisions depending on what's available locally. The other group, of course, will be the brain mets patients. I mean, one of the things that I was going to mention was the other group of new studies that will be coming through. We're going to have a plethora of data, I think, in the next year or so. So if we're looking at patina, which is this idea of upping the maintenance therapy when you're in the maintenance. So there will be a number of other different studies reporting, I think, in that area, looking at, I think, the tucatinib, the HER2, I think it's HER2-CLIMB-05. There'll be the oral SERD studies reading out. And then importantly, there's going to be, towards the end of the year, we will see TDXD in early breast cancer in both the neoadjuvant and adjuvant settings for very high-risk patients. So I think that's going to change the landscape again, isn't it?
Well, the landscape is moving so quickly, much quicker than 10 or 20 years ago, and it generates all these gaps in knowledge. What would we do if these substances would be used earlier, and what will we give as a subsequent therapy? And people sometimes complain about that situation, but I don't think it needs any complaining, because every study which is a positive study is a good signal, and the earlier in the therapy lines the studies are conducted and are positive, it's always a very, very good signal for the patients. If I have a positive study like Destiny Breast 11 study, we don't know the results yet, but there was a press release that this neoadjuvant trial shows superiority of TDXD in the neoadjuvant setting. Hopefully that effect also transfers as all the HER2-positive trials in an invasive disease with survival benefit, or even in an overall survival benefit. That would be the best case scenario. I wouldn't complain a moment about having used that substance in the early breast cancer setting and then maybe not have it available anymore in the metastatic setting, because that's the top spot medication can earn for itself. to help patients in the curable setting not to get metastasis or even not die from the disease. So there's lots of stuff going on. I'm not sure about the post-neoadjuvant study. We still have to wait for that. But there's also first-line studies in the maintenance therapy going on with the tucatinib, like the HER2-Climb-5 study. So we have to wait for what's happening there. But for now, I think we can be very satisfied with the DESTINY-Breast09 study in the first-line setting, having an option to extend progression-free survival by about 15 months with a palbociclib, CDK4/6 inhibitors. It seems to be the usual tolerability that we have. There don't seem any synergistic or additive side effects that we don't know from the regular combination therapy with an endocrine treatment, again, extending the progression-free survival time by about 15 months. It's all in all very good messages for the patients with a stage 4 first-line HER2-positive breast cancer.
So I think the key takeaway there is lots of good options. We're almost spoilt for choice, but we shouldn't grumble because having lots of good treatments for our patients and improving, in fact, we've got lots of different ways in which we can improve PFS and potentially overall survival. I think this is, as you say, something to be celebrated. I do feel like we stand on the precipice of a paradigm shift for the management of HER2-positive breast cancer. So I think we're out of time. So Peter, thank you for this great discussion. Always a pleasure. And to our audience, thank you for participating in this activity. I'd be grateful if you'd continue on to answer the questions that follow and complete the evaluation. Thank you.